Hello, my name is Davide Capodanno. I'm delighted to invite you to watch this Meet the Trialist session that is today dedicated to Dan-NICAD-2, one trial that has been presented here at the ESC 2022. And I'm also delighted to welcome Dr. Morten Bottcher from Aarhus, Denmark, who is the primary investigator who presented in the main arena in the room Barcelona the results of this trial. As a background information, this is not a randomized study, and we know that in randomized design, it's easy to say, okay, this was a positive and neutral trial. Here, things are more nuanced, so I think we are in the perfect venue to better understand the results and put them into context, because this was a very important study that addresses a very topical question for our practice. So I would start by asking Professor Bottcher, first of all, something about the background. Why did you think of this study? What is the unmet need?
So we investigate a lot of patients with cardiac CT, and we know that most of the patients will actually not have disease, but 25% of the patients will have a lesion which we think is important. And in the European guidelines, they actually recommend that you always do a non-invasive ischemia test. So you would send the patient to some form of ischemia test, but the problem with the guideline is that it's not recommended which perfusion test you should use. And the performance of a perfusion test in this setting is not really elucidated by previous studies. So this was sort of the unmet need that we thought we could fill in. And we've done a previous trial where we tested SPECT scanning versus 1.5 Tesla. So now we wanted to use sort of the more advanced PET scanning and 3 Tesla MR to see whether that improved the sensitivity when we compared it with invasive angiography.
Yeah, I totally agree that this is really one of the unmet needs. In practice, I'm seeing in my institution that now many patients are referred to invasive coronary angiography because of a CT. So basically it's anatomical testing, calling for anatomical testing, and in the end we miss that information on ischemia and we need something more. And so it's in the end it's bad when you just stop the invasive coronary angiography and ask for a non-invasive test. You have of course FFR, which was your gold standard, but in the end you need this link between anatomy and physiology. So tell us something about the methodology for comparing these two different techniques.
So basically we just took a very large sample of patients referred for coronary CT, and then if they had a suspected stenosis, and this was done locally, they were randomized to which order they should have the 2 scans, but they had both scans. So we have a head-to-head comparison. It's the same patients that we're comparing. So we're very certain that we have no noise in the sense that we have 2 different populations. It is the same population that is head-to-head that we're comparing. And we did everything we could to have the best reading of the studies. We utilized all the things that we usually utilize. Of course, it's interesting that less than half of the patients that were thought to have a stenosis in the CT scan actually had an FFR positive lesion. So it is a problem that if we send everybody with a suspected stenosis on the CT scan to an angiography, only 40% of them will have a PCI, and that's of course if we could bring that down so that most patients who go from CT to invasive angiography, they should need PCI. It's very low with only 40% having to undergo revascularization.
I totally agree, and this is somehow the frustrating part of our job as interventionists, when you see that in the end there is discrepancy, first of all, between the CT and invasive coronary angiography, and that is where you want to objectify that the patient really needs. And of course, when we don't have non-invasive testing, we go for FFR. Just one practical curiosity for those who are not really very used to PET scan and of course the cardiac magnetic resonance, because this is not widely available in all the centers. Of course, we have to acknowledge that. Is there any reason to exclude patients from these investigations? So what were the exclusion criteria in your study?
Yeah, so We only included patients that we thought could undergo the stress test and the MR scanner. So if the patient knew that they had severe claustrophobia, they were not randomized, because then we knew that we couldn't do the MR scan. Of course, other exclusion criteria were just basically based on the fact that we thought that they would be able to undergo the stress test. So if they couldn't tolerate adenosine, if they had AV block or any but I mean, it was just regular clinical contraindications for doing the stress test. That was the only exclusion criteria. Otherwise, you just had to be referred to a cardiac CT, and then you could be randomized.
So it really reflects current practice in terms of which patients can access to one or the other. So what were the main results? How would you summarize the key implications?
So the key finding is really that quite a few patients actually have a normal perfusion scan but have a low FFR. I mean, that was the main finding. If we looked at 3D QCA and looked at the very severe stenosis, so more than 70% stenosis on the 3D QCA, so the very severe stenosis, they were almost always picked up by the perfusion scan, sensitivity of 90%. So that's not the problem. The problem is more that some of the lesions that are FFR positive are probably right around the 0.8 cutoff with FFR, and of course when we measured FFR in these patients, the average FFR was 0.81. So basically all the patients are right around the discrimination border. So if the FFR is just a little bit off, then you obviously will have noise in your results, and you will have people crossing from one side of the fence to the other, so it's probably also an indication that you should be a little critical with your FFR. The biology is not such that if it's 0.81, then nothing is wrong, and if it's 0.79, then you definitely need to stent right away. There are uncertainties in the FFR measurement, the guiding catheter, the response to adenosine, etc., etc. Yeah.
Yeah, that's for sure, because of course it's useful to have something which is dichotomic, because you take decision in a dichotomic way, but then of course physiology is something that happens along the spectrum of all the ischemic conditions that you may have, and of course this is a challenge also for research when you want to demonstrate something. So in the end, so how would you judge the sensitivity of the two tests and the specificity, which are the two key parameters here to judge?
So the specificity in general was quite good. So it's quite rare that you will find a patient with a perfusion defect and then when they go to invasive angiography you will find nothing. So the specificity is quite good, I think. So the issue is really the sensitivity, and of course you can, whenever you do a test to avoid something and the test is negative and they still have a problem, then you're a little worried, can I use this, can I trust it? Because when I know that 4 in 10 will actually have a low FFR even though the perfusion scan is normal, is that acceptable in terms of patient management? What you might speculate is that if you have a patient who doesn't have a perfusion defect but have a decreased FFR, the ischemia might not be so severe, and it might be easier to just handle the patient medically. Whereas if you have a large perfusion defect and a low FFR, maybe the likelihood that you will get the patient free of angina will be lower. So maybe it can sort of guide whether you should start off by a medical treatment or whether you should go straight to invasive angiography.
This reminds me of a conversation that the task force of the guidelines for chronic coronary syndrome had at the very start. The chairpersons made sure we understood as task force members that we have to work in a different environment as compared with the previous guideline, because the prevalence of coronary artery disease is much lower than you would expect based on symptoms, sex, so the typicality of the symptoms. So it was clear since the very beginning that these tests are more useful to rule out out the disease rather than rule in the disease, which is the next big challenge. But I believe it's still relevant to exclude some patients from the chapter of coronary artery disease because they can be reassured, and in the end you reinforce the finding of the CT, which was equivocal because we said that they had some stenosis, and of course this means that you will continue with secondary prevention, etc. So one of the curiosity that I have is, of course, you have tested 2 second-line tests, I would say. Many doctors would be tempted to do the same with the stress echo, with the exercise test. What would be your recommendation regarding this first level, let's say, test?
Yeah. So where I work, we're in the fortunate situation that we can afford not to do a treadmill test because we know that the sensitivity and specificity of the treadmill test is really terrible. So actually, in our national guideline, it's discouraged. It's stated that you should not use it. So I would definitely not recommend to do a treadmill test as a follow-up on your CT scan. That doesn't make any sense. Dobutamine echo. I think it's very operator dependent, and you might have people that are really good at it, but again, I think sensitivity specificity is not optimal. But of course, as you say, we've moved from a situation where we used the treadmill test as a filter. The filter was very bad, so we sent a lot of patients without disease to coronary angiography, and we missed a lot of patients who actually had the disease. So I think the situation we have now with easy access to cardiac CT, where you find all the sick people, you might overcall some stenosis, but you're not missing anybody with severe disease. And the other thing is that I think the most benefit is probably done by finding patients who have premature atherosclerosis and can be put on preventive medical therapy. That's probably the best thing we do. It's not actually treating the patients with stenosis. That's for symptomatology, but the medical treatment can be guided. You can't guide the medical therapy by the exercise ECG. It doesn't make any sense. So
I totally agree. And actually, when it comes to the exercise test, there was also the temptation to give a class 3 because, of course, I agree that it's not really sensible and specific. But we also acknowledge that there is a wide use of the exercise test, and now the role as a class 2B is more to objectify the symptoms and reproduce the EKG changes during exercise to make sure that those symptoms are cardiac in nature. So probably this is not really a diagnostic role, but something that will make more objective symptoms that are subjective by definition in a way. So what are the next steps? Are you thinking of a third trial testing other diagnostic modalities?
So we have one trial ongoing, which is the Dan-NICAD-2, very original, but in that we compare water PET with rubidium PET, because water PET is sort of the new kid on the block. You can do very precise quantification, and we wanted to see whether that could somehow improve our sensitivity, that we could actually have an absolute quantification of perfusion. And then I think the next step would really be to have what I would call algorithm studies. So you sort of follow one algorithm, you're guided by your perfusion scan or you're guided by your invasive scan, and then see how well the patients are doing in terms of symptoms, instead of focusing on whether you actually find stenosis that are FFR positive. I think it's important that we look at how are these patients doing, are they coping with the angina, can we reduce their medication, and can we control them on medication, because we have to realize that invasive procedures are costly, they involve a small but serious risk and so on. So somehow we need to refine the way we individualize both the diagnostic algorithm and the treatment algorithms, and I think that's going to be the next step, that we now know how things are progressing. Perhaps we could also benefit from CT-FFR, whichever modality we want to use with that, but that might also add into our algorithm somehow.
Okay, so if there are questions to our trialists, of course, they are absolutely welcome. I think we can also give a message on the role of these diagnostic modalities in the current area of the ischemia trial, in a way, because of course if the trial shows that there is no advantage of an invasive strategy over medical therapy in patients with moderate to severe ischemia, then someone wonder why we should look actively for moderate to severe ischemia. What's your opinion on that?
I mean, I would hate to, when I have a program of patients, sometimes you come over somebody who might have some atypical symptoms and they have very, very severe disease. So I think it's good that we find these patients with very severe disease who definitely needs bypass surgery or at least extensive revascularization. So I think just leaving that out, that would be crazy. But I think we might be in a situation where we can do less diagnostic testing and rely on the medical therapy as long as we rule out that they have prognostic disease.
Yeah, and perhaps it's also reassuring to say that in your study, patients with left main disease, three-vessel disease, those with more critical stenosis were better captured by this test than others.
Only 1 out of 31 patients were missed by the perfusion scan. And you could, I mean, this is something for the study that you can always argue, should you include all patients no matter what you find on the CT scan? That's what we did. Or should you have some sort of a emergency exit if the CT scan is really, really bad, then you should just send those directly to angiography without the perfusion scan. I mean, you could argue that you don't need that because if you have triple vessel disease, you can almost see it on the CT scan, and those can be taken out. So I think in future studies we would probably have sort of an emergency exit for the very severe patients. So.
Okay, thank you very much for this deep dive into the implication of this important trial. We very much look forward to the publication, also to understand more. Thank you very much. Thank you for watching this Meet the Trialist session, and thank you.